Hi friends, greetings of the day. Today we will discuss about disorders of puberty part 2. In part 1 we have discussed about physiology of puberty and also about central precocious puberty. Now we will discuss about peripheral precocious puberty. You already know that precocious puberty is of two types: central, also called as complete or two precocious puberty; peripheral precocious puberty, also called as incomplete or gonadotropin independent. It is incomplete because it does not follow the complete HBG axis and does not follow the normal stages of the development of physiological development of puberty. That's why it's called incomplete. That we discussed in previous lecture detailedly why we will call it as incomplete precocious puberty. So we already discussed that central precocious puberty is always isosexual in previous lecture, but peripheral precocious puberty can be isosexual or heterosexual. So peripheral precocious puberty can be isosexual or heterosexual. First we will discuss about the etiology causing isosexual precocious puberty, then we will go to heterosexual precocious puberty. I already discussed in previous lecture about what is called as isosexual. Isosexual means if the boy is a male, he will have the same external and internal genitalia as male external and internal genitalia. If the person is a female, she will have female external and internal genitalia. But in heterosexual, the external and internal genitalia does not correspond with their gender. Okay, here the genitalia correspond with their gender, so it's called isosexual. So isosexual causes of precocious puberty in males are HCG secreting tumors. HCG secreting tumors are the only causes in males because this HCG will directly stimulate the testosterone only. So HCG secreting tumors are not causes of precocious puberty in females. They are causes of precocious puberty in only males. Okay. CNS HCG secreting tumors are examples: chorioepithelioma, germinoma, and teratoma. Outside CNS, there are hepatoblastoma, choriocarcinoma, teratoma. Teratoma is seen in CNS and also outside CNS. So CNS are chorioepithelioma, germinoma, teratoma. Outside CNS, hepatoblastoma, choriocarcinoma, teratoma. Okay. So HCG secreting tumors is one of the cause for isosexual peripheral precocious puberty in males. These are the only causes in males. In females, they are not the causes. And other causes are androgen secreting adrenal or testicular tumors. Androgens are testosterone and dihydroepiandrosterone. So whenever the androgens are secreting more, there will be precocious puberty. Okay, the androgen secreting adrenal I already discussed. Because of the androgens GnRH, LH, FSH and DHEA, there will be precocious puberty. GnRH, LH, FSH are the causes for central precocious puberty, whereas androgens are causes for peripheral precocious puberty. Androgen secreting adrenal or testicular causes are congenital adrenal hyperplasia. In previous lecture, in congenital adrenal hyperplasia lecture, if you see my endocrinology playlist, there will be congenital adrenal hyperplasia lecture. There I discussed that 21 hydroxylase and 11 beta hydroxylase deficiencies will lead to increased androgen secretion. Because there is a blockage of cortisol secretion, all the premetabolites will lead to the increased androgen secretion in 21 hydroxylase and 11 beta hydroxylase deficiency. This lead to increased androgen and precocious puberty. You can see my congenital adrenal hyperplasia video for detailed discussion. Okay, next are tumors, adrenal tumors which produce more dihydroepiandrosterone, DHEA. Okay, and Leydig cell tumors produce more testosterone. So tumors of adrenal or testis. Okay, adrenal tumors, Leydig cell tumors, and familial testotoxicose. It's autosomal dominant condition where the testis is functions very high. So it is called testotoxicosis. the testosterone release is very high. It is an autosomal dominant condition. Okay. And cortisol resistance, it's a rare condition, cortisol resistance syndrome. The receptors for cortisol will not are not effective, so cortisol cannot act on the receptors and it will keep on increasing in the body. So cortisol also have the action like gonadotropins. So this cortisol will all increased cortisol will also cause the precocious puberty. Okay, because the receptors are not functioning, there will be increased levels of cortisol in the body. It has side effects like of a action like androgens. It has side effect action like androgens. So this will also cause increased cortisol will also cause precocious puberty. Familial toxicosis is an exemption because testicular volume is normally, as I discussed in previous lecture, in peripheral precocious puberty, testicular volume will be less, means it is pre-pubertal, because if in gonadotropin precocious puberty only it is increased, but this peripheral precocious puberty is non-gonadotropin, so testicular volume is pre-pubertal. But the only condition is familial testotoxicosis and also HCG secreting tumors. In these two conditions, HCG secreting tumors and familial testotoxicosis, these are the two conditions in peripheral precocious puberty where testicular volume is high. This is contrast to the peripheral precocity. Okay, so in peripheral precocity the testicular volume is pre-pubertal, means less, because it's not gonadotropin dependent. Detail I discussed in previous lecture, please view it. And but in familial testotoxicosis and HCG tumors, the testicular volume is high, which is contrast to peripheral precocious puberty. Okay, here we discuss the causes of isosexual precocious puberty, peripheral precocious puberty in males. Now we will come to the females. Okay, causes in females. Isosexual precocious puberty. Causes in females are ovarian cyst, ovarian tumors, adrenal tumors. Okay, androgen secreting ovarian tumors and adrenal tumors. Okay, estrogen secreting ovarian tumors and adrenal tumors. Is because they are females, the sex hormone in females is estrogen, so estrogen secreting ovarian tumors and adrenal tumors and ovarian cysts, and also Peutz-Jeghers syndrome. This cause the isosexual, mean in precocious puberty, peripheral precocious puberty in females. Okay, the genital organs are also same like females, because the sex steroid secreting is the female sex steroid only, estrogen, but the secretion is increased levels of estrogen secretion is there due to ovarian tumors and adrenal tumors. It will lead to the precocious puberty, but it is isosexual. Okay, isosexual. And other cause is Peutz-Jeghers syndrome. Now we have discussed isosexual causes in males of peripheral precocious puberty in males and females. HCG secreting tumors, I already told, they are causes only in males. They don't cause in females. Okay, precocious puberty. Causes in both sexes are McCune-Albright syndrome, and hypothyroidism, exposure to androgenic or exogenous sex steroids. So in some conditions, many cosmetics and in some treatments with exogenous steroids, sex steroids. In females, if they are using estrogens, and males if they are using testosterone, there will be isosexual precocious puberty, peripheral precocious puberty. In males, if they are using external testosterone, and females if they are using external estrogen, like many cosmetics like for breast implantation, etc. So these may lead to precocious puberty. Okay, external exposure to androgenic or exogenous sex steroids. And McCune-Albright syndrome is a triad of capillary spots, precocious puberty, and bone abnormalities. Hypothyroidism. In hypothyroidism, there is a rise of TSH. TSH acts is having an action on the FSH receptors. So it will lead to inducing FSH-like effects. So increase in TSH will lead to FSH-like effect. Okay, in hypothyroidism, leading to precocious puberty. You understand? Okay, causes in both sexes. So now we have discussed about isosexual cause of peripheral precocious puberty in males, females, and in both sexes. In both sexes, McCune-Albright, hypothyroidism, estrogen to exposure to exogenous and iatrogenic sex steroids. In females, for isosexual, it's not androgens, it's estrogen, because isosexual should have the same sex steroid hormone synthesis. So estrogen is the female sex steroid hormone. So which tumors or which conditions secrete more estrogen, they lead to the isosexual precocious puberty in females. Okay, next we will isosexual we have discussed. Next we will go to the heterosexual etiology. Heterosexual etiology is virilizing in females, virilization in females, and feminization in males. So if the females, if they are exposed to much virilizing androgenic hormones from the fetal period or neonatal period only, they will lead to they will have external genitalia as males. Okay, and they will be so it is heterosexual because the females will have external genitalia as males. Okay, and because of excess exposure to androgens, these females who look like males, they will have external genitalia of males, and the testicular volume, all those things will be the penile length and development of pubic hair will be very fast. Means it will be in though they are females, the male external genitalia develop in early ages because of excess secretion of androgens. The causes are increased androgen producing tumor, androgen production from adrenal or ovaries. So we already discussed in isosexual precocious puberty in males, which secrete androgen like CAH, 21 hydroxylase, and 11. So all these causes, CAH, adenocortical tumors, and ovarian tumors which secrete androgens. Okay, all these causes will lead to the heterosexual precocious puberty in females. Okay, and androgen aromatase deficiency, adrenal or ovarian tumors which secrete androgens. Okay, and congenital adrenal hyperplasia, examples 21 hydroxylase deficiency and 11 beta hydroxylase deficiency. You can see the video of CAH I discussed there in detail. So this lead to the increased androgen production. The conditions which lead to increased androgen production and virilization in females will lead to the heterosexual precocious puberty in females. So this is the etiology of peripheral precocious puberty, isosexual and heterosexual. Isosexual can be divided into males, females, and both sexes. Heterosexual, in females virilizing causes, and in males excessive feminizing causes. So in males also, if there are any estrogen secreting tumors, or if there is deficiency of testosterone or androgens, excessive deficiency of androgens, then they will look like males. So it is heterosexual, and they develop the breast and breast tissue and everything in the early ages. Okay, in males also, feminizing conditions in females and virilizing conditions in females, and feminizing conditions in males. Okay, next we will come to the approach. Approach the girl with thelarche before 8 years, thelarche breast development before 8 years. So investigations to be done are LH, basal LH and GnRH stimulated LH. If in basal LH and GnRH stimulated LH, if the LH is more than 0.3 international units, so in gonadotropin, the LH should be more gonadotropin dependent or central precocious puberty. So if it is more, then we can suspect central precocious puberty and can go to the MRI. If MRI is normal, it is idiopathic precocious puberty. I already discussed about idiopathic central precocious puberty in previous class. If MRI is abnormal, we can suspect intracranial space occupying lesion or hypothalamic hematoma. Okay, hypothalamic hematoma. Next is hypothalamic. So if MRI is abnormal, we can suspect ICSOL or hypothalamic hematoma. If stimulated LH or basal LH is less than 0.3 international units, then it is peripheral precocious puberty in females. Then you should go for USG uterus and ovaries. If it is positive, means if any ovarian tumor or cyst or your uterus size is more and ovarian cysts are present, then we can suspect that ovarian tumors or cysts are present. These are leading to the precocious puberty, isosexual precocious puberty in the girls. If T3 and T4 or less, then we can suspect hypothyroidism. And if USG and ovary, if the USG uterus and ovaries are normal, then we should go for bone scan. If it is abnormal, we can go to McCune-Albright syndrome. So in this approach, we are excluding all these etiologies like McCune-Albright syndrome, hypothyroidism in girls, in females, ovarian tumors. Okay. So when we are going in approach in the females, so we should exclude all the etiology. First we excluded central precocious puberty causes. If LH is more than 0.3, then it is central precocious puberty. If MRI is normal, it is idiopathic. If MRI is abnormal, it is ICSOL and hypothalamic hematoma. I have discussed in previous lecture of central precocious puberty. In peripheral precocious puberty, the LH will be less than 0.3 international units, and we can exclude all these by USG and doing the test thyroid hormones and bone scan. Okay. Next, approach to the boy with phallic means penile enlargement before 9 years. So if a boy comes with penile enlargement and pubic hair, then we should first check for clinically for testicular volume. So already discussed that if testicular volume is more, then it is central precocious puberty. If testicular volume is less, if it is prepubertal less than 3 ml, it is peripheral precocious puberty. Then we should go for the excluding the causes of peripheral precocious puberty like congenital adrenal hyperplasia by 17 OHP levels, glucocorticoid resistance which is rare, cortisol levels should be measured, adrenal tumors, here DHA level should be measured. These are all the cause of peripheral precocious puberty should be excluded. I already discussed in the lecture. Okay. And if the length is pubertal more than 4 ml, then we should test for testosterone. I already told only exceptions for raised testicular volume in peripheral precocious puberty or HCG. Usually the testicular volume is more in central precocious puberty. The exceptions are HCG secreting tumors and familial testicotoxicosis. That's why I have kept in this line. So we should exclude a central, so we should evaluate for central precocious puberty, HCG secreting tumors and familial testotoxicosis. First you do the testosterone levels. If testosterone levels are high, then check for HCG. If HCG is high, HCG secreting tumors. If LH is more than LH also you should measure. If LH is more than 0.3, then it is or GnRH stimulation test. If LH is more than 0.3, then it is central precocious puberty. Do MRI. If it is abnormal, suspect a hypothalamic hematoma, ICSOL. If the LH is less than 0.3, then it is familial testotoxicosis. So here the testotox, these are the causes of peripheral precocious puberty, but the testicular volume is high in these two. That's why first we should check the testosterone levels. If it is high, HCG levels and LH levels should be tested. In HCG secreting tumors, HCG levels will be high. In LH, if LH is very high, then it is central precocious puberty, go for MRI. And if LH is less than 0.3, it's familial testotoxicosis. If there is asymmetrical increase in the length of testes, suspect testicular tumors or congenital adrenal hyperplasia due to TART, androgen adrenal reminiscing testes. Okay, these testicular androgen reminiscing. Okay, these These tumors will secrete the androgens in the they are ectopic androgen tissue in the testes. They will secrete the adrenal androgens like DHEA. So when the testicular size is asymmetrical, that is one testis is big and other testis is normal size, then you suspect the testicular tumors or TAR tumors. So this is about approach. Mainly you should check for GnRH levels or GnRH stimulated LH, MRI, and if in females you should do USG abdomen, USG and USG uterus and ovaries, T3, T4, TSH, bone scan. In males, you should test for testotoxic. You should test for congenital adrenal hyperplasia and HCG secreting tumors, and if LH is less than 0.3, then test familial testotoxicosis. If asymmetrical, then you can go for testicular tumors. Management we'll discuss very shortly. For central precocious puberty, GnRH agonist should be given like leuprolide acetate. For hypothalamic hematoma also, I discussed previous lecture. The medical first is the medical line of management, that is GnRH agonist. They desensitize the GnRH receptors, leading to decreased activity of the GnRH on the GnRH receptors. This will help in the decreased action of GnRH. By external provision of GnRH agonists, they desensitize the GnRH receptors, so GnRH activity will be reduced and it will help the children, because in central precocious puberty the GnRH activity is very high. The exogenous supplementation of GnRH agonists like leuprolide acetate will desensitize the GnRH receptors and will help to reduce the action of GnRH. Next, for ovarian tumors, McCune-Albright syndrome, medroxyprogesterone acetate can be given. Medroxyprogesterone acetate. For familial testotoxicosis, ketoconazole, aromatase inhibitors like letrozole, flutamide or medroxyprogesterone acetate can be given. So for central precocious puberty, GnRH agonists like leuprolide acetate. For ovarian tumors and other causes of peripheral precocious puberty like McCune-Albright syndrome, medroxyprogesterone acetate can be given. Okay, and for familial testicotoxicosis, this ketoconazole and aromatase inhibitors have anti-androgen effects. Androgen inhibitor like letrozole, flutamide will have anti-androgen effects, and also medroxyprogesterone acetate can be given in familial testotoxicosis. This is a brief discussion on the management. So here in this video we mainly discuss about etiology of isosexual precocious puberty in males, females and both sexes, and etiology of heterosexual precocious puberty, virilization in females and feminization in males because it is heterosexual, and approach and diagnosis by various investigations like LH, GnRH stimulated LH and basal LH, and USG uterus and ovaries in females, and hypothyroid hormone levels, bone scan for McCune-Albright syndrome. In males, testosterone levels can be seen, and HCG levels and GnRH stimulated LH levels, same like in females, if LH levels can be seen, and MRI if you suspect central precocious puberty. Okay, and familial testotoxicosis. Here also, if you suspect central precocious puberty, MRI should be done if it is abnormal, hypothalamic hematoma. If it is normal, idiopathic central precocious puberty. Management is mainly GnRH agonists in central, in ovarian tumors and McCune-Albright syndrome, medroxyprogesterone acetate, and in familial testotoxicosis, ketoconazole, aromatase inhibitors, and medroxyprogesterone can be given. Thank you very much. If you like my video, please subscribe to my channel and press like button and share my videos. Thank you very much.